a GP by trade and working still in urgent care. So I hopefully I'm helping my colleagues by bringing a clinical perspective to all things related to COVID. Just going to give you a brief presentation about how we've decided to respond to COVID in Northern Ireland in terms of apps that we're using. Obviously, in the current environment, there's very little positive that one can draw out of it. It's having such an impact economically, emotionally, and personally on individuals. But I do think there has been a good opportunity for digital adoption. And certainly in Northern Ireland, we have had a number of initiatives that have been quite helpful in us securing adoption and for people seeing the value of digital enablement. But I'm going to focus just particularly on our two apps, COVIDCare, which are our symptom checker app, and our proximity app, which is StopCOVID based on the Google Apple API that was alluded to in earlier presentations. So whenever this broke earlier this year, we had a helpline that was introduced for the pandemic response. But we found that there was a significant pressure that the helpline was creating and generating work for GP and GP out of hours services, which was actually quite overwhelming. And when we looked into this, we found that there was a significant issue in that all clinical issues were being referred to those services without any filtering. And we saw that as a significant problem. So we introduced a triage algorithm based around the COVID definitions and checking in terms of severity and impact on aspects of daily living. And by introducing that, we produced a significant channel shift in being able to divert away people who didn't need clinical care from frontline clinical services. Having seen the value of that, we then developed an app to try and see if we could produce a further channel shift away from the helpline to try and see if that could have an impact on people's behaviors. So if we look at what was happening in the early pandemic, we were running at about 6,000, up to 6,000 calls a day. At peak, an average of about 2,500. Whenever we introduced the COVIDCare app, which basically reproduced the algorithm in an app format, we could see quite significantly that there was a channel shift. Usage of the app at peak was going through up to 6,000 journeys daily. And we had a significant fall then in use of the helpline, while we also in our urgent care services noted a very dramatic fall in calls that were happening. So if we look into that a little bit more, whenever we produced the app, we deliberately didn't do any promotion of it because we wanted the adopters to be individuals who would be potentially less impacted by illness, and therefore that channel shift would help relieve access to telephone access services such as urgent care for those who genuinely needed it and required it. At the moment, we're sitting at about 8% of the population have elected to use it. So that's 8% of the population without any promotion. And what it does is it basically checks their symptoms, gives them information about COVID guidance, also helps them with their self-isolation with an isolation timer and gives them the latest statistics. It also helps us as well, similar to our colleagues in the Republic, in that we're able to get epidemiological information that helps us to calculate our numbers and to help focus resources. So if we look at the impact, just taking last Sunday as an example, if we look at the app itself, there were about 4,000 journeys through the app in that 24-hour period. 600 of those were for symptom checks specifically. And about 27% were advised to self-manage, about 16% were directed on to other services, and 57% were screened out as not actually meeting the COVID criteria. So through the use of the app, 84% are being assisted digitally without having to access a telephone access urgent care service. We decided also as well to try and reach segments of the population that might not want to use a smartphone app. So we developed a web version in parallel to the app with the same algorithm. And if we look at last Sunday again, the same 24-hour period as an example, you can see that there were 829 symptom checks and a similar pattern in that a relatively small percentage, about 10.6%, are being directed on for further clinical assessment, whereas the vast majority are being screened out, about 89%. So if we look at that in terms of real terms, just to give it a context, on that 24-hour period, 1,246 people were screened out from accessing frontline services. So if we look at the average figures for GP out of hours on a Sunday, it's about 1,600. So that's quite significant channel shift, and about 78% of potential contacts are being screened out and giving a digital solution which really has a fantastic impact on those frontline services and reducing the pressure that they're under and improving their response time so that those who genuinely need care can access it rapidly. It also, as well as I mentioned, has given us support with calculation of reproduction rates. We also then at the end, so that symptom checker went out at the end of March. It was the first one in the UK. We also then, in discussion with our colleagues in the Republic, decided to go for a decentralized app. There's about 30,000 people crossing during normal times the border between the Republic and Northern Ireland on a daily basis. So that movement of people, 30,000 on a daily basis, was quite significant. So a key consideration for us was the idea of interoperability. And obviously to do that, we both needed to have decentralized apps, and we found our colleagues in the Republic very supportive and helpful. And we used the same company as they used to develop theirs, to develop our own proximity app, although we took a slightly different approach. So the proximity app obviously is decentralized on the Google Apple API, so it's privacy protecting, which was important in our engagement with groups such as Amnesty and privacy advocacy groups. With extensive pre-engagement, we were able to get endorsements from them that the approach that we were using was privacy protecting. Also as well, we, similar to our colleagues in the Republic, we advertised the source code and published it online, and also as well we're open with our DPIA documentation. The exposure notification service that we provide obviously is compliant with GDPR. I've just got somebody at my door, would you believe? Notification occurs within 2 hours. We process 14 days of contact. So unlike the manual process, where there is a 24-hour period, sorry, just bear with me 1 second. Please just leave it, that'll be 2 seconds. Apologies for that. You couldn't plan these things. 14 days of contacts are traced in line with the WHO evidence of pre-infectivity. So asymptomatic or pre-symptomatic carriage can be for 5 to 6 days on average, but we know that actually over up to 14 days is possible. Notification is fully automated and we don't rely on human beings to be involved in delivering authorization codes. We have an automated SMS process, which speeds up the process of notification and makes it much more effective. We also know that manual processes can extend out to 72 hours. Certainly in the peak earlier in the year, there was significant strain on manual contact processes. So we think that giving people a notification in an automated way in parallel to the manual process is more effective. So in terms of success, we launched the proximity app at the end of July. At the moment, we've had over 429,000 downloads. I think we may just have reached 430. So that is equating to about 22% of the population so far. When we launched initially, though, we were restricting it to an 18+ age group while we looked at the data privacy issues around adoption for younger users, which are a significant segment of the smartphone ownership, and also looking at the evidence base behind that. So those initial figures, since we launched in July, we've had a second version out at the end of last week, which is starting to help us with a little bit of an uptick in terms of our adoption that we've extended the use. In terms of effectiveness, if we look at the level of downloads and the ratio of exposure notifications to uploads of diagnosis keys, we can get a feel for the effectiveness of the app. So at the moment, we're averaging about 3.4 exposure notifications for every upload of diagnosis keys. If you compare that to the average in manual contact tracing, it's 2.7 in Northern Ireland. So we can show that the digital solution is actually highly effective and breaking chains of transmission. This particular peak was just due to an aberration where SMS messages went out late at night when a batch of tests came through, and then the notifications went out the next day. So it sort of distorted the figures for that one day. But that average, we think, shows a high level of effectiveness. In terms of exposure notifications, so far over 8,000 people have been notified of an exposure risk and advised to self-isolate since the app was launched. So that's quite a significant impact in terms of reducing chains of transmission. And if you look at our excess mortality data, along with our colleagues in the Republic, we've had very low levels of excess mortality apart from the early part of the pandemic phase. And we think we're making an effective contribution alongside our manual contact tracing process. So where we're at now in terms of the age range, we've extended use from 11 to 17-year-olds upwards. We included that post-primary age group on the back of the research from Singapore, which shows quite clearly that post-primary age group are just as likely to transmit COVID as an adult. And as a result of that, we've had extensive engagement with schools, and we have also engaged with trade unions and a number of children's advocacy groups to try and ensure that we could do this effectively and within the law. We also engaged in extensive focus group work with 11 to 17-year-olds from diverse backgrounds and with diverse educational attainment to make sure that we were designing something that they were likely to use. We then also circled back and produced a user interface for them to be able for us to refine what we were doing to ensure that what we were doing was age appropriate and that we could set our banding appropriately to make sure that they would have a sensible experience. We also engaged with our Information Commissioner's Office, our Commissioner for Children and Young People, and the Children's Law Centre to make sure that there was really good stakeholder engagement so that it would be accepted as a reasonable thing to do. Essentially, what we've ended up with is a banded approach where the youngest age groups are being advised to speak to a parent or guardian about exposure notifications, that there's an age-appropriate onboarding process, and that we try and use very simplified language to support children to be able to use this effectively. I think that that's actually been quite an innovation. And just to highlight as well, interoperability with the Republic, that was a world first. So we have interoperability working effectively. We've had about 2,000 and 2,000 to 2,500 exchange of keys across the border since that went live at the end of July. And it's working effectively, and we think it's a very useful tool. I will stop sharing my screen there. Apologies for the interruption, and hopefully there'll be some questions.
No problem for the interruption. Thanks a lot, Eddie. Do you have an idea about the uptake in the different communities or regions in Northern Ireland?
Well, we know that our symptom checker app, because we collect postcode information in the symptom checker, we have universal adoption well represented across all postcodes. So we've engaged with our local universities to look at effectiveness, and certainly for the symptom checker, there is universal coverage. To be GDPR compliant and comply with our ICO's guidance on best policy for adoption of this proximity app, we have not been collecting any user-specific data about postcode or anything of that nature. We just simply know the total number of users, the number of uploads of diagnosis keys, and the number of exposures at a exposure notifications at a regional level. And we're doing that to get our CE accreditation. But to try and promote public trust and confidence, we deliberately haven't been collecting postcode information to be able to discern that.
Yeah, thanks. And so the app is interoperable with the app in the Republic of Ireland. But what happens if you travel to the other regions of UK?
Well, at the moment, the Scottish have launched their app at the last month. We are in advanced discussions. We have the technical capability for interoperability between the Republic and Northern Ireland and Scotland. And we're planning to activate that interoperability east-west within the next couple of weeks. We also are in advanced discussions with colleagues in England and Wales who've just recently launched their app. And the plan is to have that within the next few weeks and hopefully by the end of the month to have that interoperability in place. The technical solution is currently being developed at the moment, so it's a little bit behind interoperability with Scotland, but it's well advanced, and we plan to have interoperability across the common travel area by the end of the month.
Yeah, thanks, Eddie. So now